Hey guys, welcome back to step 3 review. This is part 3. If you're just coming off watching part 2, I found out that GBS, the CSF thing I was thinking about, was albuminocytologic dissociation, which just means that the albumin, the amount of albumin and the amount of cells, cytologic, is not proportional. So the amount of protein is a lot higher than the cell number in GBS. And don't get that confused with CJD, Creutzfeldt-Jakob, where you have the 14-3-3 protein found in the CSF. So in today's review series, we'll just do some other high-yield topics. One really big one that I was thinking to talk about today is congenital immunodeficiencies, because there's a lot of them, and usually in step 3 pediatrics, it's a highly tested topic. So let's just jump right into it. We can start talking about the B cell line deficiencies, kind of split it up into B cell line deficiencies and T cell line deficiencies, and go into some high yield points about each. So let's start with B cell lines. And the first B cell line we're going to talk about today is Burton's A-gamma globulinemia. So this is a X-linked recessive disease, and what you'll see about these immunodeficiencies is a lot of them are X-linked recessive. So the patient usually in the vignette is going to be a boy. I would say in 99% of the cases. So Bruton's is a deficiency in the BTK gene. So if you think Bruton's, you think B cell, you think BTK gene, and you think boys. So that's all the BBBs. Now what the BTK gene does, the Bruton tyrosine kinase, is it helps to mature the B cell. So if the B cell doesn't mature, you're going to have a deficiency of mature B cells, and therefore a deficiency of mature immunoglobulins being produced. So in these patients, you're going to have they're at around 3 to 6 months when the immunoglobulins of the mother in the bloodstream, kind of the maternal IgG, start waning at that time. At 6 months, you start to have recurring infections. And these are usually pyogenic infections, pneumonia, otitis. You'll have encapsulated bacteria starting to invade in the patient. And you can also see other things like viruses, enterovirus, hepatitis viruses starting to draw their effect if they're there to begin with, or if the child has exposure. So Bruton's is around 6 months, 6-month-old boys. That's when you're going to see it, and you're going to have absent or low levels of B cells. And remember, the B cell markers, those CD markers, are 19, 20, and 21. And T cell count will of course be normal. And B cells are a very important fraction of lymphoid tissue. So you're not going to have those germinal centers. If they give you a histological slide in one of these cases, the germinal centers of those follicles are going to be missing. So make sure you watch out for they like to throw histology in on the test as well. How do you treat it? So you're going to compensate by giving immunoglobulins IV, so IVIG, and you'll also give prophylactic antibiotics to these patients. Another important thing about Bruton's is because you don't have antibodies, you really need to avoid live vaccines. So a really important one is MMR. This is contraindicated in people with Bruton's because it has a high chance of causing an actual infection. Alright, so we've covered Bruton's. Let's just go over it very quickly. It's B cells, boys, BTK gene, and and you'll also see it at 6 months, and you'll have CD19, 20, 21 low because your B cells are gone, germinal centers are gone. You treat it with IVIG and prophylactic antibiotics. Next is selective IgA deficiency. Selective IgA deficiency is actually the most common immunodeficiency, characterized by a near absence of all IgAs. So you're going to have a very low IgA if you test it in the serum. The real cause of IgA deficiency is most likely a differentiation you know how all antibodies come from IgM and then they differentiate into IgG, IgA, IgD. Well, that's most likely one of the etiologies, but the primary one hasn't really been worked out yet. Often these people with IgA are going to be asymptomatic. Usually they'll have, but if they do present, they're going to have things like respiratory infections, sinus infections, diarrhea. So the mucosal membranes are associated with IgA deficiency. Just remember that. And associated diseases with IgA are things like gluten insensitivity, celiac, IBD, ITP, and anaphylaxis. So these people are going to be those allergy type kids. Allergies, anaphylaxis, chronic ongoing respiratory and GI infections. IgG and IgM will actually be normal, just IgA will be deficient. And you can also actually, another interesting thing about IgA deficiency is that you can get false positive pregnancy tests. Now this is probably due to heterophile antibodies interfering with the HCG test. So the varying levels of IgG, IgM, the other heterophiles in the line, they could interfere with false pregnancy tests. And the IgA, you can divide it into like Bruton's, you have a bunch of B's. IgA, you can divide it into A's as well. So IgA, A for asymptomatic, A for airways, A for anaphylaxis, A for autoimmune, and A for atopy. Another thing that is important to remember about IgA is that these people will have anaphylaxis to blood transfusions because they don't have IgA and now you're giving them someone else's. So now they're going to have an immune reaction from that foreign IgA. Okay. So let's go over a quick review of IgA deficiency. So asymptomatic, you're going to have chronic diarrhea or upper respiratory tract infections. If they do present, you're going to have possibly false pregnancy tests and also possibly anaphylaxis from blood transfusions. Next is CVID, common variable immunodeficiency. So common variable immunodeficiency is another one of these B cell problems. It's you're going to have low levels of immunoglobulins despite pretty much normal B cells. So in Burton's we have immature B cells. In CVID our B cells are normal but our immunoglobulins are still low. So they're not able to, in this case the mature B cells are unable to differentiate IgG producing or immunoglobulin producing into immunoglobulin producing cells. So you have very low immunoglobulin levels, but they are matured. In these patients, you're going to have the classic sinopulmonary infections. You can have a high risk of lymphoma, gastric cancers, autoimmune disorders. With any of these low immunodeficiency states, you are always increasing your risk for autoimmune problems because your immune system is it's essentially dysregulated. You don't have mature immune cells to deal with the potentially malfunctioning ones as well. How do you diagnose this? So you're going to have a low immunoglobulins across the board, G, A, and M, all low. You're going to have decreased numbers of plasma cells, even though your B cells are fine. So this is, if you think of the B cell in 3 stages, immature to mature to plasma cell. Immature to mature will be Burton's. Immature to plasma cell is going to be CVID. Okay, and then you'll have normal numbers of B and T cells, just decreased plasma cells. For these people, you can also give IVIG and prophylactic antibodies. Now, really, how do you differentiate CVID from Burton's? And that's from the B cell analysis. So immature to mature, remember that, and then plasma cells. So if you have low plasma cells and low mature B cells, you have Burton's, and if you just have low plasma cells, you have CVID, which is less severe because you're inhibiting the pathway at the kind of end stage. Next, we're going to go to DeGeorge syndrome. Now we've kind of completed our little roundabout of B cell disorders. So we're going to jump to DiGeorge, which is a T cell. So now we're in the T cell disorder range. We have DiGeorge, which is a 22q11 deletion syndrome. This is essentially a defective development of the pharyngeal pouches, the third and the fourth one. And these are essentially the pouches that form the thymus, where all of your T cells are matured and trained. So really the acronym for DiGeorge syndrome, just like we talked about the A's and the B's for Burton's, calling them an IgA, we talked about the A's. Here we have CATCH. So DiGeorge is also known as CATCH22. The 22 refers to chromosome 22, and each of the letters of CATCH represents something. So C is cardiac abnormalities, and this can be structural or conductive. So usually you'll have people with ASDs, VSDs. They can have tetralogy of Fallot, truncus arteriosus. So they'll have one structural, usually a structural abnormality. Then A is anomalous facies, which just means their face looks a little bit strange. You have prominent nasal bridges, things like that. Dysplastic ears are the common ones also seen. T is has to do with the thymus, and essentially you have recurrent infections because your thymus is not working. So these are viral, fungal, things like PCP pneumonia, things you can see with AIDS or an immunodeficient state. And these are due to T cell deficiencies. And then C is cleft palate. That again goes with probably our anomalous facies, but we just needed a C to complete the catch. And then H is hypoparathyroidism. So your parathyroid hormone will be low, your calcium will be low, your PTH is a hormone that's required to bring in calcium from the gut and from the kidneys. So you have a hypocalcemic, immune deficient kid with heart problems and a strange face. Okay, that's DiGeorge syndrome in a nutshell. Remember, in these kids, you have to do PCP prophylaxis. Remember, pneumocystis pneumonia is a common infection for these kids. They essentially have like a new onset AIDS or severe combined immunodeficiency, where your T cells are very important with dealing with a lot of these bacterial infections. And you also have to look for a possible thymus transplant if you catch it early enough. If you catch it early enough, you can actually give the child a new thymus, and in some centers around the world it's been shown to be beneficial. So CATCH22 was for DiGeorge. Next, we're going to talk about autosomal dominant hyperimmunoglobulin E syndrome, which is also more commonly known as Job syndrome. So hyper IgE syndrome. This is, as it says in the name, autosomal dominant. So this is not one of our X-linked syndromes. And so is DiGeorge, by the way. DiGeorge is also autosomal dominant. So for the B cells, we were X-linked. Here we're autosomal dominant. And the etiology for a hyper IgE is a deficiency in a gene called STAT3. Now what that does is, if you mutate STAT3, you have inhibition or malfunctioning of the Th17 cells. And the helper T helper 17 cells are really the ones that kind of modulate your neutrophil and macrophage function. So your phagocytic cells are not working well anymore. And the the acronym to remember here, because each of these comes kind of with their own acronym, is FATED, F-A-T-E-D. F is for facies, of course, facies. A is for abscesses. T is for teeth, so you have a retained primary teeth. Usually these kids have two sets of teeth, one in the front and one kind of just behind it, so you'll catch that in an image they'll show you. E is eosinophilia and also IgE, because IgE is associated with increased eosinophils, increased allergies. Essentially, IgE also protects the skin, so you'll have the abscesses on the skin from deficiency in IgE. And D is a dermatologic, so eczema and things like that. So if you think of IgA as the kind of protector of your mucosal membranes, your respiratory tract, your GI tract, you can think of IgE as the protector of your skin. So you'll have eczema, abscesses presenting on the skin from IgE deficiency. And also you can think of it as your eosinophil modulator. So that was Job syndrome in a nutshell. Stat3, Th17, coarse facies. These kids are going to have extra teeth, abscesses, eczema, and eosinophilia. With also, one other thing that I forgot to mention is these kids have decreased bone density and increased fracture risk. Now the etiology for that I'm not sure, but that's one more thing you need to watch out for Job syndrome. So in summary, faded facies, abscesses, teeth, IgE, eosinophilia, and severe eczema and bone fragility. That's Job syndrome in a nutshell. Now we're going to go on to IL-12 deficiency. This is another one of the kind of T-cell associated immunodeficiencies. Essentially, T helper cell type 1 is associated with IL-12 receptors, and this one, unlike the other two, is autosomal recessive. So now the macrophages and the T helper cells can't really interact well because the IL-12 receptor is deformed or not working properly, so they can't coordinate cytotoxicity towards pathogens. Now if you have an IL-12 deficiency, you'll often get things with infections of intracellular pathogens. So those intracellular pathogens, their elimination is really determined by coordination between the macrophage and the T cell, because it kind of helps to present the intracellular pathogen to the original T helper cell, which then passes on the signal to the macrophage. And in these people with the IL-12 deficiency, you'll have usually a mycobacterial infection. These people tend to easily develop tuberculosis, also fungal infections, and its diagnosis is through decreased interferon gamma. So the macrophage, interferon gamma, and IL-12 all work together in conjunction with the T cell to become active. And if you disactivate this process, you have intracellular pathogens, tuberculosis, and fungus that thrive in these situations. This one's a bit more of a low yield one, so we've just gone through it very quickly. Next, we have chronic mucocutaneous candidiasis. This is also an impaired T cell disorder, and the AIR gene, or the AIR protein, here is the dysfunctional one. That's a very common cause, and the interleukin is IL-17. So IL-12 was for our previous condition, the IL-12 receptor for our intracellular bugs. Now for our Candida, IL-17 is the cell-mediated defender here. And essentially you have recurrent candidal skin infections in the mucous membranes and the nails. If you see Candida, it'll have this bright red borders. It's usually found in the skin folds. But with this disseminated or mucocutaneous candidiasis, you can have it really all over the body. So it doesn't have that typical Candida presentation. You can diagnose it with usually candidal antigen test. So you can put Candida antigen and T cells together, and if you have them in a petri dish, the T cells will usually proliferate and try to attack the Candida, but in this case it's not going to happen because IL-17 is missing to mediate that attack. Alright, so next, in this kind of candidal chronic mucocutaneous candidiasis, remember IL-17, remember Candida appearing in the mucous membranes, and doesn't have that classic skin fold infection, but it'll tell you in the question stem that it's a Candida infection. Alright, moving down the list, we have Ipex syndrome. Ipex syndrome is immune dysregulation. So Ipex actually stands for something. It's immune dysregulation, polyendocrinopathy, and enteropathy, which is X-linked. So I is immune dysregulation, P polyendocrinopathy, E enteropathy, and X is X-linked. And just like all the other X-linked ones, this one is X-linked recessive, but it's found in T cells. So the majority of them are either going to be autosomal dominant or X-linked recessive, and if you're looking for an immune disease. All right, so in Ipex syndrome, you have a deficiency in the transcription factor FOXP3, and this causes unchecked activation of T cells against host tissues. So this is one of the more autoimmune type immunodeficiencies. So instead of attacking the bugs, you're attacking yourself. You're going to have chronic eczema. See, T cells are one of the main contributors to things like autoimmune skin conditions like eczema, psoriasis, and things like that. You can have endocrine disorders, so you're going to have type 1 diabetes, hypothyroidism, or hyperthyroidism, and enteropathy like chronic diarrhea. In the question stem, they'll usually give you a person who, they have an endocrine disorder. They're going to have the eczema present. Because it's polyendocrinopathy, they might give you a thyroid problem as well. And it's going to be in a young boy. And they're also going to be predisposed to a bunch of infections. So it's going to be a young boy who has an infection somewhere on their body. They're going to have a thyroid problem, type 1 diabetes, and chronic diarrhea. And you're going to be wondering, wow, this seems like a host of random problems. Just remember that Ipex syndrome is a thing, and usually the treatment for this is going to be things like immunosuppressants. Rituximab is one of the go-to. Tacrolimus, sirolimus are the immune regulators found there. All right, now the next thing I think we should talk about is severe combined immunodeficiency, Wiskott-Aldridge, hyper-IgM, and then we can tackle some of the not T cell, not B cell disorders, some of the phagocytic cell disorders, because we still haven't covered those. So if we're going to continue down the T cell line, we've finished with the T cell line. We've done Ipex syndrome, we've done mucocutaneous candidiasis, IL-12 deficiency. These ones are, and Job syndrome. These ones are really our T cell mediated disorders. So quick review, just so we can keep our minds fresh with the disorders. Which ones are B cells, which ones are T cells? B cells is going to be Burton's, it's going to be IgA deficiency, it's going to be common variable immunodeficiency, and then T cells is going to be our DiGeorge, our IgE, hyper IgE. Remember, hyper IgE is a T cell disorder, and IgA deficiency is a B cell disorder. Don't mix those up. And then IL-12 deficiency is also a T cell, candidiasis, and Ipex syndrome, also T cell. Now, if we're going to have a mixed disorder, the main one here to remember is SCID. So SCID disorder is a genetic disorder. It's pretty rare. And essentially you have decreased production of functional B as well as T cells. Now the etiology can either be X-linked recessive or autosomal recessive based on the type of SCID you have. So the X-linked recessive SCID is a defective problem in encoding the gamma chain. So it's there's a gene that encodes the common gamma chain of immunoglobulins, and this gamma chain also causes defective gamma chain production of the interleukin receptors like JAK3. So gamma encoding SCID is X-linked recessive. This is the most common type of SCID. Then the second most common is autosomal recessive SCID, also known as adenosine deaminase deficiency SCID. This is an association of you aren't able to get rid of adenosine with adenosine deaminase. Now you have toxic metabolites building up. You have a deoxyadenosine essentially building up and in purine metabolism processing inside of your immune cells, and that causes their destruction. Okay, and they're also not able to proliferate because you need adenosine to replicate your genes. Okay, so two main types of SCID to remember: the gamma chain, which inhibits IL-2R, and the adenosine deaminase SCID. Chronic features of SCID are things like, so when you're born, you're going to have your antibodies from your mom and some base immune function, so you're going to be normal at birth. Then afterwards, the child's going to have recurrent infections. You're going to have diarrhea, candidiasis, protozoal infections, things like that. Diarrhea is a very common one they like to throw in there. Lymph nodes and tonsils will also be absent because you have no B and T cells to form that lymphatic tissue. All right, and then if you have SCID, you're gonna want to do a PCR test to diagnose it. So you're gonna have a PCR test to detect T cell receptor excision circles, or TRECs. If you have a low number of these TRECs, SCID is highly likely in the diagnosis. You can also do flow cytometry for T cells, which will be present in SCID. You won't have a thymic shadow on the chest x-ray. Thymic shadows, remember, are pretty prominent in children. So you'll see no thymus, and if you do a lymph node biopsy, you won't be able to find any tissue because these people essentially don't have functional lymphatic tissue. All right, so SCID is a mutation in of genes that are heavily involved in lymphatic tissue production, the gamma chain of IL-2R, the adenosine deaminase that's involved in producing B and T cells. The children will be normal at birth, but then start getting recurrent infections, failure to thrive, absent lymph nodes, absent thymus, things like that. Remember to differentiate this from DiGeorge syndrome, where it's kind of a selective deficiency of T cells. How do you treat this? Well, IVIG, because you don't have B cells to produce your immunoglobulins or any kind of mature cells. You're going to need PCP prophylaxis for pneumocystis. Pneumocystis is a very common infection in immunocompromised children, and you're going to need new immune cells. So you're going to need new bone marrow to produce your immature B and T cells in order for you to have some kind of functioning immunity. And also remember to avoid live vaccines in these kind of immunocompromised children. So we've covered SCID. Now let's talk about Wiskott-Aldrich syndrome. Wiskott-Aldrich, you can remember with the water or whisper mnemonic. W is Wiskott Aldrich in whisper, so or WA is Wiskott-Aldrich in water. T is thrombocytopenia. E is eczema, and R is recurrent infection. So I like water more. Some people like whisper, which is Wiskott-Aldrich, purpura, eczema, and recurrent infection, but they're essentially the same thing. The mutation in Wiskott-Aldrich is the WASP gene, the WASP gene. It's an X-linked recessive gene. Remember, X-linked recessive, if you had to put your money on something for immunodeficiencies on a test, I'd go with X-linked recessive if you were just guessing. And what the WASP gene does is it's a protein that's important in cytoskeleton linking. So you have an impaired actin cytoskeleton reorganization, which causes decreased antigen presentation in cells. So you're not able to present that antigen to a macrophage or T cell. And now you're not able to essentially mount an effective immune response. One of the other things that you need actin cytoskeleton for is the production of platelets from your megakaryocytes. So you're going to usually find purpura or bleeding diastases in these people. And then eczema, I'm not 100% sure how that one works, but it's part of the infectious, or part of the triad of this disease. So purpura, eczema, and recurrent infections are the three things you're going to find with Scott-Aldrich. Curiously, you're going to have decreased IgG and M and increased IgG and A. The synthesis for IgG and A is paradoxically gone up. I'm not sure how that works. So if anybody has insight, you can throw it down in the comments below. And again, treatment with IVIG, prophylactic antibiotics. Here you want to add on a platelet transfusion if the platelet count is low enough. Usually that's about 30,000 with bleeding and less than 10,000 without bleeding. And you can also do stem cell transplants if you're in an advanced center and you want to be curative. Hyper IgM. So we've talked about a few antibodies, IgE, IgA so far, and now we have IgM. And this is a mixed B and T cell problem. Essentially, this IgM syndrome impairs the interaction between T helper and B cells, resulting in a lack of B cell class switching. So it involves the T cell because you need IgM to help with your B T cell link that allows for class switching. You need the T helper cell to interact with your B cell properly in order for the class switching to be induced. So it's an X-linked recessive gene of CD40L in the T helper cell. This is a T helper cell mutation of CD40L. Now, because you don't have the CD40L interaction with the B cell, CD40 receptor, you have a disruption in class switching. So you're going to have very high IgM levels because that's the only antibody structure you can produce now, and IgG, A, E are going to be low. And the problem with this is you're going to have increased infections because you really need specialized antibodies to deal with certain bugs. So Cryptosporidium is going to be one of the ones that likes to invade here. PCP again. The histoplasma are opportunistic in these cases. CMV, so CMV hepatitis is one of the hallmark infections here. And again, you treat with IV immunoglobulins, and you have prophylactic antibiotics for those bugs. All right, and the final one we have for the kind of mixed disorders is ataxia telangiectasia. This is an autosomal recessive defect in the ATM gene, which leads to defective DNA, double-stranded DNA break repair, and now you have essentially tumor development, infection development, as well as combined B and T cell deficiency. So in the ataxia telangiectasia, you're obviously going to see ataxia, so the patient's not going to be able to walk properly. You have muscle hypotonia, truncal swaying, things like that. And then you'll see those classic vascular telangiectasias, spider angiomas, mainly involving the conjunctiva and the face. So in these people, you have three things: ataxia, you're not walking properly; telangiectasia, so you have those spider veins in your corneas and on your face; and then immunodeficiency. So IgA deficiency is very common, and these people have recurrent mucocutaneous infections in their genes. So the 4A, ATM, 4A for ataxia telangiectasia, ATM, ataxia, angioma, IgA. These are very common. And one thing to watch out for here is you want to, in people with ATM, ataxia telangiectasia, you want to avoid radiation. You want to avoid doing CT scans because they are at a very high risk for malignancy. They essentially can't do double-stranded gene repair, so X-rays are going to can commonly cause double-stranded breaks in genes, and you're putting them at further risk by giving them like a pan-CT, for example. Essentially, don't go to an emergency room if you have this immunodeficiency. All right. So we've covered the combined immunodeficiencies. Let's just go through the list again, make sure we remember which ones those are. These are SCID, Wiskott-Aldrich. So SCID, we have our recessive mutation in our gamma chain, our X-linked recessive mutation in our gamma chain, or our autosomal recessive mutation in adenosine deaminase. We have Wiskott-Aldrich syndrome, which is our WASP gene, which is X-linked recessive. Remember, you have the eczema there, you have the recurrent infections, the palpable purpura, the thrombocytopenia, hyper IgM syndrome, which is a CD40 ligand deficiency of the T helper cell. You have your recurrent infections with CMV, cryptosporidium, opportunistic infections with that one, and you're going to have high IgM and low other immunoglobulins, IgAE, for example, G, the ones that are commonly tested for. And then ataxia telangiectasia, where you have double-stranded DNA repair being inhibited, and you have increased likelihood for tumors, inability to walk properly. Ataxia telangiectasia is on the face, and reduced IgA, so mucocutaneous infections. Next, we're going to talk about the last congenital infection problem, which is going to be congenital neutrophils and phagocyte disorders. Now, this is turning out to be a bit of a longer talk, so today we're just going to go long. We're just going to see how this goes. We're going to try to cover everything, because I think it would be comprehensive to have everything in one video instead of splitting this up. So for neutrophils and phagocyte disorders, the main one that most people are going to want to know about is CGD, or chronic granulomatous disease. This is essentially a defect in superoxide dismutase, and if you've seen my previous video on the reactive oxygen species video, you need superoxide dismutase to process reactive oxygen species and also create the necessary reactive oxygen species for destroying bacteria. Essentially, if you have this deficiency, you're going to have recurrent infections with catalase positive organisms, because now you aren't able to produce the end products of your superoxide reaction chain, and you're left with the catalase sensitive oxygen, reactive oxygen species, which can be handled by these catalase positive organisms that include things like Staph aureus, Nocardia, E. coli, Candida. You can also have lymphadenopathy in these cases, because the lymphatic tissue is trying to compensate. It's growing, and it's going to be large. And granulomas are going to form in the skin, because now that you're not able to effectively deal with these bugs, essentially the best your body can do is wall them off. Okay, so this is an X-linked or autosomal recessive inheritance pattern. More commonly, it's going to be X-linked in a 2-to-1 versus autosomal recessive. So 2 times more people are going to have X-linked disease. And now that your phagocytes aren't working, your NADPH oxidase is not producing your reactive oxygen. So before I said it was a superoxide dismutase problem. I'm sorry, it's a superoxide production problem. Just going to correct myself there. So this is an NADPH oxidase problem, and that's the first step in the reactive oxygen species production line. Okay, so your respiratory burst in neutrophils is not working, and NADPH oxidase is not working. This is X-linked recessive. You're going to have lymphadenopathy, granulomas. If you do a neutrophil assay to diagnose this, remember the main diagnostic for this is going to be the dihydroamine test, which is essentially a flow cytometry test that shows if NADPH oxidase is working or not, based on fluorescent products. So dihydroamine, if it's not processed through reactive oxygen, NADPH oxidase, you're going to have less green fluorescence in your in your test tube or in your end product. So dihydrorhodamine in flow cytometry, if NADPH oxidase is not working, so if you're positive for the disease, you'll have reduced green fluorescence compared to a control. The other test is nitroblue tetrazolium, and this is essentially you incubate leukocytes and they fail to turn blue because they aren't able to produce the reactive oxygen species in the test. So nitroblue tetrazolium is blue, is the positive. If you don't have the disease, the test reagent will turn blue, and if you for dihydrorhodamine, if you don't have the disease, you'll have high amounts of green fluorescence. So this test is based on the reduced amount of blue and green in your end resultant tubes. It's getting pretty late on, so I'm starting to get more and more delirious as we talk. So just to correct myself, we were talking about chronic granulomatous disease. This is most commonly X-linked recessive. It's a deficiency in NADPH oxidase, not superoxide dismutase. What you aren't forming is superoxide products in your respiratory burst pathway. And now you're susceptible to catalase positive organisms. Remember that you diagnose this with dihydrorhodamine and nitrotetrazolium blue. So that's dihydrorhodamine turns green if you're negative, and nitrotetrazolium blue turns blue if you are negative. And then you have a treatment essentially of this disease with either bone marrow transplant or lifelong antibiotics. Some studies have also shown that interferon gamma works. And now, more newly, they're starting to do things like gene therapy for this condition. Okay, so NADPH oxidase gene for CGD. Just remember that. That's the main point here. Catalase positive organisms. Leukocyte adhesion deficiency is going to be one of our problems that are also associated with neutrophils and phagocytes, and this one is associated with autosomal recessive inheritance. You're going to have absence of the beta-2 integrin adhesion product. So the integrins are affected in leukocyte adhesion deficiency. Integrins are kind of what help the lymphocytic cells penetrate through blood vessels and reach their targets. So CD18 is one of those integrins, and it allows for migration of the leukocytes to their intended target. If you don't have it, essentially the transport of leukocytes is inhibited, so you're going to have recurrent non-suppurative bacterial infections. Non-suppurative because you aren't forming pus, and you need neutrophils to form pus, and because the neutrophils can't go out of the blood vessels, you can't form pus, and so these children have these infections that are essentially red. You'll see them, they look inflamed, but there's no drainage of pus from them. And then one of the common findings here, usually what they'll show you on test, is a delayed separation of the umbilical cord. You need neutrophils to kind of eat up that necrotic umbilical cord to let it fall off. So 2 weeks postpartum, the umbilical cord is not falling off, and it looks infected, but it's not pustular. You could have this condition. You're also going to have leukocytosis in the blood. So if you do a WBC count on these kids, their leukocyte count is going to be huge. And if you do flow cytometry, your CD18 is going to be low. And how you treat this is you could do prevention, so adequate dental hygiene, adequate skin hygiene. You could do prophylactic antibiotics for these kids, and eventually you might need a bone marrow transplant to replete these integrin genes. Okay, Chidiac-Higashi syndrome is another very common one that's tested, and in Chidiac-Higashi you have a deficiency of neutrophil chemotaxis by microtubule dysfunction. So you can't form the phagolysosome inside of the neutrophil in Shinya-Kagashi because the microtubules aren't working to move things around intracellularly like they should be. And so lysosomes aren't trafficked efficiently, your phagolysosomes aren't formed properly, you have an increased risk of infection. Now that not only affects things like immune cells when you're forming phagolysosomes, but also it can affect your pigment producing cells. So your melanocytes now can't really export melanin, so you have these people commonly suffering with albinism as well. So on top of getting recurrent pyogenic infections, your albinism, your person is likely to have albinism. So the neutrophils are getting to their site, so you're getting pustular pyogenic infections. Just they're really ineffective at dealing with the bug because the phagolysosomes, when they're eating it, are not working to process it properly. And in these cases, you'll have giant cytoplasmic granules. If you look under the microscope, these granules are essentially unprocessed bacteria that the phagocytic cells are working on but can't destroy. So if you remember Alpine for Shinya-Kagashi, that can be your little mnemonic, and that's albinism, lymphohistiocytosis, peripheral neuropathy can also be seen. You need the microtubules to work for neurochemicals to be sent between neurons for neurotransmission. Infections is the I, and neurodegeneration, neutropenia is N, and is the N in Alpine. You can have either neurodegeneration, neutropenia. These neutrophils, they're not functioning properly, and so they tend to die off quickly because they get clogged up by all this bacterial debris that's not able to be processed. Then we have myeloperoxidase deficiency. Myeloperoxidase deficiency is further down a reactive oxygen species chain link, and essentially if you don't have the MPO gene, which is autosomal recessively inherited, you get this problem. And remember when we talked about in our reactive oxygen species video, you need NPO to kind of deal with, to produce essentially bleach inside of your phagocytic cells and kill candida. So myeloperoxidase deficiency is going to be associated heavily with candidal infections. And many people are usually asymptomatic. Candida is not as common to infect you as other bugs like Staph aureus, for example. But in these people, you'll also have a positive, if you test them with nitrotetrazolium blue, you'll have a positive test because your NADPH oxidase is working. Let's say you're working to kind of figure out why these people are getting these recurrent infections. You have preserved respiratory NADPH burst, but now your end product, your MPO, is not working. So the final product of the pathway is not killing these fungal invaders. So you're going to have a person here with recurrent fungal infection. There's no real specific treatment for this. You just treat the fungal infections as they come. But luckily for these people, their early pathway still works, so the bacterial infections are usually handled just fine. And then for our final thing, we have severe congenital neutropenia, which is a neutrophil deficiency at birth due to a myeloid lineage disease. This is pretty much autosomal recessive or X-linked recessive, depending on the gene affected, and the gene is usually called HAX1. In these cases, the patients will get recurrent bacterial infections. You'll get gingivitis, otitis, respiratory infections. Those are the very common places to get things like staph and strep. Oral ulcers will be recurrent in these people from those infections, and you have essentially low neutrophils with reactive monocytes. So the monocytes are going to try to compensate an increase, but you can't. How do you treat this? You can give these people GCSF to try to stimulate their white blood cell lines, and you can also try to do a hematopoietic cell transplant. Take those hematopoietic cells and try to stimulate white blood cell production in the bone by transplanting them. This one, severe congenital neutropenia, is pretty rarely tested, but I just included it here for our completeness sake. And in the next video, I think one of the other immunodeficiency things we can cover are the complement deficiencies like C3, C1, MAC complex. Those are would be the final thing, but I think this video has gone on for close to an hour now, so we're gonna cut it off here. If you have any questions or comments, if anything I said was incorrect, just feel free to post it in the comments and we'll get to it and we can further our discussion. So we've done a pretty good overview of the immunodeficiencies seen in children, the B cell, the T cell, the combined, the phagocytic cell deficiencies. And I hope this has been a good review, and I'll see you guys in the next review segment.